I'm talking about some new diagnostic tools. There are some repetitions of Jay's talk because he talked about the new one as well. That's our problem, as we know. The problem is also, and we discussed it yesterday when we talked about the consensus meeting, behind all these different topics about periprosthetic joint infection, there's standing a big question mark, and especially behind diagnosis. Here, of course, there is no doubt that's an infected joint, without any doubt. But why is it so difficult to diagnose a periprosthetic joint infection? Because the bacteria, they have some ways to hide themselves, for example, into the cells itself, or as Jay already reported, they are able to colonize the bone canaliculi, and we cannot remove them from them, and we cannot diagnose them into these little canaliculi. The main symptom, as we've heard yesterday, of course, is pain, and this is quite easy, but is a very, very sensitive tool, but not very specific. And you can be always misleaded in your daily work. For example, if pus comes out, it's not an infection in all cases. It could be a metal-on-metal combination. So that leads to the fact that we have a lot of proposals for definitions of periprosthetic infection and diagnostic algorithms from the MSIS, from our international consensus, from the Infectious Disease Society of America, that shows you that there is still a lot of uncertainty about diagnosis. For many countries, there is a reflex to exclude the infection by performing a scintigraphy. But this is also very, very questionable, because more and more publications came to the conclusion that scintigraphy is almost useless to diagnose a periprosthetic joint infection. So in the majority of our cases, we came up with synovial fluid, diagnosis of the synovial fluid. Unfortunately, microbiology is not really successful. In average, all over the world, the accuracy of and the chance to find the germ by culture it's about 60 to 7%, which is not very satisfying. Cell counting is much better, of course. The problem with cell counting is that you have a lot of different cutoffs. So some authors mentioned that the cutoff is more than 2,500, others more than 1,700, and for some others it's 1,100, and so on. We did a study recently in almost 340 cases, infected cases, where we determined the cutoff for knees, it was 1,600, and for hips, 3,000. So take in your mind, there are different cutoffs, obviously, for the knees and the hips if you count the cells. Sonication could be a quite good tool. It's not available in every country here in the world. It's a quite good tool. For me, it's a little bit problematic because of the of a lot of false positive results. Here you solve the biofilm by performing ultrasound. Another opportunity, quite new opportunity, could be the chemical solving the solution of the biofilm, which was described by the group from Italy around Drago and Romano. But if we compare all our current diagnostic tools, we must say they all have strengths and weaknesses. So for me, and this is always a very good recommendation in all parts of the world, Jay's idea was genius to take the leukocyte esterase strips as a diagnostic tool. And nowadays we know that leukocyte esterase is extremely sensitive, much more sensitive than any other tools, almost any other tools that we have. What about histology? You can send samples of the loosening membrane to your pathologist. We came up with a histopathological consensus classification, which we elaborated during the last 15 years, and we differentiated 4 kinds of loosening membrane of the soft tissue. One kind, type 2, was the infection type. Multiplex PCR could be an option. We did a study about it. It was not really satisfying. Sensitivity was 85% in the best cases, but in the average case it was just 78%. So it was a little bit disappointing in comparison, for example, to the leukocyte esterase test, where you had 89% in our series as well. So what we really needed probably are the biomarkers to detect, like pregnancy test or cardiac troponin test, to detect a periprostatic joint infection. And during the last years, especially in Philadelphia, they tested a lot of them, and they found out that the alpha-defensin probably is one of the best tests because it's a natural antimicrobial peptide which is induced by the pathogen. The neutrophil is secreting alpha-defensin, which kills the pathogen. A lot of publication came out with very good results about alpha-defensin. We did some own studies about it. We found really good results, sensitivity of the alpha-defensin in the lab test, in the serum of 90, in the synovial fluid, 97%, 70%. But we had also false positive cases for alpha-defensin. Mainly, if there is a metal-on-metal reaction, then you have a false positive alpha-defensin test. So we did some other studies which quite good results, less false positive. And recently we looked after the Synovajur test, which is something like the pregnancy test. This is a little stick where you can detect an infection or not the bacteria, of course, but to be sure it is infected or not within 5 to 10 minutes. Accuracy of this test is very good. We looked after 200 patients and found out that the accuracy is about 97% again. And here another very recent paper, 90-70%. Came out a systematic review about this 3 months ago with quite good sensitivity for the lateral flow test, that means the stick, and much better sensitivity for the ELISA test. This is based mainly on 2 poor publications from Austria, as you can see here down, where they reported just a sensitivity of 69%, but no other study could repeat it. So what is really new, all ideas of my friend Jay, serum markers for BGI, D-dimer could be a very, very good diagnostical tool. They did many studies about it, and they found that in contradiction to erythrocyte sedimentation rate and CRP in the synovial fluid, and the number of false positives is quite low. D-dimer seems to be a very, very good test. We are still not know why and how we should treat with it. Some other papers came out with synovial calprotectin, quite good sensitivity, but limited sample of 19 patients. Another came out with a new lateral flow test where they determines the IL-6 with a very high sensitivity, specificity, also limited sample of 26 patients, and so on and so on. So there are so many attempts at the moment to improve our diagnostics, and probably the future is this, what Jay already mentioned. I do not want to repeat everything what he said. Probably only one interesting thing, with the next-gen sequencing, you can detect, or you are looking after the whole genome, as Jay mentioned already. The Human Genome Project, probably some of you remember these times at the end of the 80s, beginning of the 90s. They needed 13 years to detect and to determine the whole genome, and it cost $3 billion. And now we have, Rasman did a very nice study. Now the cost has declined really rapidly. It's about $190 that for the whole genome, and it needs less than 1 day. So probably this is really the future, and Jay and I, we hardly believe in it, and that's the reason why we are performing this multi-center study at the moment. Thank you so much.